We are going to have a really interesting presentation relative to pharmaceutical costs and some opportunities there. I know that we hear a lot about the rising costs of pharmaceuticals, and I was just looking here that some data shows that overall the United States spent about $330 billion on prescription drugs in 2017, which was a 40% increase from 2007. That includes public and private spending, meaning that includes out-of-pocket costs. That includes what employees are paying and what your employees are paying, as well as employers. So today we are again honored to have Bob McCollins with us. He has we partner with Bob quite a bit at the Kansas Business Group on Health, and he's actually presented before. And we work with him on several of our services. Bob brings 35 plus years of employee benefit consulting and sales experience in the leadership role he now has as the managing director of the Employers Advanced Cooperative on Healthcare. And then I believe also we will have Mark Owens, who is a benefit plan advisor with ICI and is one of our, ICI is one of our broker members. So Bob, I am going to go ahead and turn it over to you and we'll get started.
Great, I appreciate that. And Matt, I think you have the slides, so I'll wait for you to pop those up. In the meantime, to Matt and Shelley and Dr. Moore, what a great morning of information that you shared so far. Really appreciate being able to listen in. As an interested coalition, leader and advisor to take some things back to our employers. So, really do appreciate you letting us be a part of this, and then also to share some information on prescription drug costs and pharmacy benefit managers. So what we're going to cover today, Mark and myself, number one, I'll kind of start off sharing a general understanding of pharmacy benefit managers, the differences between PBMs that exist. We'll also share some strategies for some of the higher cost drugs and risk and management solutions there. Mark is going to share strategies and experiences from an employer perspective. And then we'll close with, as Shelley identified, just a brief introduction of a new Kansas Business Group on Health employer offering for a pharmacy benefit solution for those who might consider an alternative to what you're doing. So why the focus on prescription drugs? Well, employer concerns, as we understand in 2021, and some have already been addressed today, diabetes and managing chronic conditions, behavioral health, obviously getting a lot of attention for all of the right reasons that it should. Employers are concerned with the cost of high cost medical claims, and generally always at the top of the list in the top 3 or 4 are their prescription drug costs in total, but then also specifically specialty drug costs. If we considered prescription drug costs or pharmacy benefits as a disease category similar to cancer, heart, diabetes, it's likely that it would be employers' number 1 disease category. And that's supported by the fact that as an industry, what we're seeing now that prescription drug costs for employers are now commonly approaching 25 to 30% of total medical and pharmacy costs for employers. And we're even seeing it in some employers as high as 40%. So it's an epidemic that deserves attention by employers and by their advisors. Matt, next slide, please. So as we consider pharmacy benefit managers and pharmacy benefit costs, certainly it's getting a lot of attention, especially those pharmacy benefit managers are getting a lot of attention in the press, in the media, in our attention, and generally, quite frankly, over the last couple of years, not necessarily for the right or the best reasons. So what I'd like to do is take a few minutes and kind of break down the different models of pharmacy benefit managers, or PBMs, because that's a lot easier to say. Before I do, I want to emphasize a couple things. Number one, there is no one right answer. There's no one size fits all solution for each employer. There's strengths and weaknesses. There's positive and negatives for each one of these approaches. So it really comes down to the second emphasis, which is for you to determine your priorities for your plan as you consider a PBM partner, just like you would any other supply chain partner, whether it's related to your health plan or to your business. So you really have to consider there's not one right answer. It's what's best for you and what are your priorities that you're looking to accomplish. So if we look at the different models, we're going to start on the far left with the traditional model. And we equate the traditional model to PBMs such as CVS, Express Scripts, Walgreens, Optum. Those are the big jumbo Bahama Mamas in the industry. They have great brand recognition. Components of a traditional model PBM, their size dictates that they can generate big volumes of discounts on purchasing of prescription drugs. Their volume maximizes rebates within their program. They often have little or no administrative fee. They're leveraging the concept of spread pricing. There is very limited transparency and no formulary control or plan design flexibility for the employer, but you're leveraging big, that gets big discounts and big rebates for the employer. If we go all the way over to the far right in the transparent model, this is an approach that's getting a lot of attention, but generally it's from pharmacy benefit managers that people haven't necessarily heard of, such as a USRX or a Southern Scripts or a Navitus or RX Benefits. And a transparent model is more focused on an actual or true cost type of approach. There's more focus on delivering a lowest net cost per member per month solution than there is emphasis on rebates. And where a traditional model has little or no administrative fees, transparent models have administrative fees often in the range of $8 to $11 per script that's charged to the employer. But with that, there's full transparency of the admin fees that they are disclosed, and they are the only source of revenue for the transparent model. Their contract terms are fully auditable and transparent. And in a transparent model, the employer generally has total control of the formulary and the plan design for their plan. And then in the middle, you have what's been developed and we call a hybrid model. So this would be organizations like a Magellan or a Maxwell Plus, a Prime or a Med Impact. So they're kind of taking pieces and parts of a traditional program, pieces and parts of a transparent program and putting them together. There's still some focus on rebates. But there's a little more sharing of revenue. There's more disclosure and transparency of their business practice and charging of administrative fees, and some limited but available formulary control and plan design flexibility for the employer. Matt, next slide, please. So as we further analyze the different models of pharmacy benefit managers and looking at their pricing practices, again, in the traditional model, this is an approach that the formulary model is, again, developed to maximize high volumes, to offer greater discounts and generate big rebates. Their spread pricing approach may benefit pharma more than the employer, but again, you're trading brand recognition and big power and discounts and rebates to benefit your decision. In the industry, what we're seeing for the traditional model, average costs range between $105 and $135 per member per month for delivering a prescription drug solution to a traditional model. The rebates generated are averaging somewhere between $20 and $35 per member per month. So as you go across this slide and you look at the hybrid model, again, a formulary mix that does focus on some lower cost drugs, yet still has a preference towards rebates. You see a little lower cost, average cost of 90 to 110, but you see that the rebates, while still important, are less than the traditional model. And then the transparent model, again, is focused on an actual cost, not really influenced by rebates. And again, you can see the average costs there per member per month are ranging between $70 and $95, but a much lower return on rebates back to the plan. So again, it really comes down to determining your priorities. Is having a big network and a name brand important? Then that traditional model is one that you're probably going to lean towards. Where does your interest in capturing or gathering rebates for your plan, is that important? Or are you really looking at focusing on the lowest net cost per member per month? Again, as you consider these, you have to consider that big brand generates very little noise. As a consultant told me one time many years ago, Bob, nobody ever got fired for recommending Blue Cross Blue Shield. And again, as you consider your choice of PBMs in the different models and what you want to focus on delivering your priorities for your plan, the less noise that you want, a traditional model is going to be a good choice. A transparent model is going to have a little more meat to it, is going to cause a little more noise, a little more prior authorization or medical necessity enforcement, maybe even a smaller network to drive better solutions. So those are things that you want to consider. If you're not sure of your per member per month cost for your pharmacy program, then on the Kansas Business Group on Health website under Employer's Choice RX, there is a really nice calculator that you can input just a couple of data sets, one being your annual pharmacy costs, the other being your average covered members per month. And it will give you the results and will allow you to see what your actual per member per month costs would be in your plan if that's something that you're unsure of. Next slide, please. So as we consider the employer concerns of high cost specialty drugs, we have a little survey question here. So Matt, I'm going to get you teed up for the survey. The question is, specialty drug costs are now reaching 40 to 50% of total prescription spend for employers. So considering that almost half of your total costs are relative to prescription drugs, what percentage of your covered population is driving that 40 to 50%? Is it 20% of your covered population? Is it 2%? Is it 10%? Or is it greater than 20%? So we'll give you a few seconds and watch the polling and the results go up here, and we'll reveal the answer in just a few seconds. And it's typical when I ask this in a presentation, we get answers all across the board. So we'll wait just a couple more seconds and then we'll move on and give you the answer. So it looks like we've kind of leveled out. So the winner of the results, we're showing 10%. That's a little bit high. The actual answer is 2%. 2% of your covered population is driving 40 to 50% of your entire prescription drug costs, generally those related to higher cost specialty drugs. So if we can clear that and then move on to, oh, it is cleared. I need to clear it off mine. So how do we address high cost specialty drugs? And again, the choice of PBM is also going to drive your ability to take advantage of this specific program. Your traditional PBM, again, is set up to drive big discounts and maximize rebates. So the approach of using manufacturers assistance programs and or international pharmacy solution services to address high-cost specialty drugs likely won't be allowed in a traditional PBM. Compared to a transparent PBM, they are most likely going to allow a manufacturer's assistance program because, again, they're less concerned about rebates and more concerned about lowest per member per month cost. So if we look at this slide, and as you can hopefully see some of the numbers, this is actually about a 300 employee life group that's participating in a manufacturer's assistance program through a transparent pharmacy benefit manager. This is a 3-month snapshot of people who have chosen to participate and have been able to get their prescription drugs sourced through either a manufacturer's assistance program or an international pharmacy solution. In looking at this 3-month, if you look under RX savings for the employer, this employer has saved by participating in these programs $53,000. How a manufacturing assistance program works is the manufacturers offer prescription drug support for high-cost drugs. There are certain qualifications that the individual must meet, primarily financial qualifications. But if a person, depending upon the manufacturer, and let's take Humira, that bottom one as an example, which is a very common drug that you'll see in your utilization. It's an anti-inflammatory drug, most likely to address rheumatoid arthritis or ulcerative colitis or Crohn's, a very common drug in your utilization. Humira generally runs per dose about $5,000 to $6,000 up to about $12,000 a dose. If you look at this graph in the bottom one, Humira, there was an individual that qualified for the Humira Manufacturer's Assistance Program. What this meant for the employer is that manufacturer is now supplying that drug direct to the patient at no cost to the employer because the individual qualified for manufacturer's assistance. So this employer saved for that month's supply of Humira $11,000. You take that out over 12 months, that's over $120,000 that's saved to the employer plan. The incentive for the patient to participate in a program like this, to provide the information necessary for qualification, generally the employer will waive any out-of-pocket costs for the employee to participate. So in addition to the employer saving a significant amount of money, the patient also saves any out-of-pocket costs or copay associated that they might have as a part of their prescription drug plan. Again, as we're considering ways to better manage prescription drug costs, in addition to prior authorization and medical necessity and paying more attention to that, there's also manufacturer's assistance programs that many of these drugs will qualify for that would allow employers to save a significant amount of money, not only on their plan, but oftentimes it also eliminates the need for a laser from the stop-loss carrier for a self-funded program. So this may be something that you're not taking advantage of. It may be because you're in a traditional PBM and in lieu of free, you're getting significant rebates credited back to your plan. Again, make decisions based on your priorities and what's best for you and your situation for your employees and their work families and the cost of your healthcare plan. Any questions so far before I move on? Just checking in. I'm going to take that.
I don't see any.
Okay, great. Well, let me have the pleasure of introducing Mark Owens. Mark is Vice President of Employee Benefits with ICI Insurance in Wichita, Kansas, but he's also the advisor to Central Christian Church in Wichita, Kansas. And Mark's going to take a few minutes to present an employer perspective on prescription drug management, strategies and experiences that they have had at Central Christian Church. So Mark, I will turn it over to you.
Thank you, Bob. Um, we met Bob through the Kansas Business Group on Health, so I really appreciate Shelley and Matt introducing us to Bob. We've really developed a partnership because of the value that he brings and ECRX brings. And so we started talking last year in the summer and decided to start bringing them into our plans, our partially self-funded plans. And it's made an impact immediately. So I wanted to kind of bring what Bob was talking about from a higher level standpoint down to a practical case study, just so you can kind of see an example of what this has meant to one of our groups. This is obviously a nonprofit group, about 150 employees between school and the church. They're dependent upon tithing and gifts and giving. So their health insurance costs are their second largest line item, extremely important. And we, about 3 years ago, we started working with them, and we moved them, first of all, immediately to a partially self-funded platform. They went down from about $900,000 fully insured bill each year with a national status quo traditional carrier. When they moved to an independent TPA in a partially self-funded plan, their cost dropped to about $600,000. So they saved about $300,000 just doing that only. Also, we installed a DPC, direct primary care option in the group. About 25% of the employees tried it, and they're about 75% of them are now fully on that primary care plan. Also, we switched medical management partners to one that focuses on employee steerage to the highest quality, lower cost, better value providers. And we waived the employees' cost sharing, which has been phenomenal. And then we eliminated the provider network and moved the group to reference-based pricing, which has dropped costs even more. So one of the smartest things we did, though, was we brought Bob and ECRX. We moved the former PBM out and put ECRX in as of October 1 of this year. And I want to just give you a quick little case study of one of the employees. We have an employee whose spouse has MS. It's an expensive condition. She was on a very expensive drug called Tecfidera. It runs anywhere from $8,000 to $9,000 per month. And the former PBM was basically, as most PBMs do, they just rubber stamp it, and she was going to the pharmacy and filling that drug, and it was costing Central a tremendous amount of money each year. So what ECRX did, they immediately flagged this prescription and started sourcing it at alternative sources. They were able to find the drug through a tier 1 country, international drug sourcing, the same exact drug, Tecfidera. And they were able to get it for $31.20 a month. So it was formerly $8,000 a month. They were able to get the same exact drug by sourcing it internationally for $31.20. That drug is mailed every 90 days to the plan member, so they have it delivered to their home. This created an immediate savings of almost $5,000 a month for the group and about $60,000 a year, which you can imagine for a nonprofit, that's significant. So that's just one case study, and that was just in the first 3 months of ECRX being on the plan. So it's already paid for itself just in the first quarter of that plan. We've been extremely impressed with ECRX and working with them, because customer service is extremely important, and being able to work with independent brokers and being able to get questions answered and work through situations. They've worked with employees on the MAP program, the Manufacturers Assistance Program. They really do a great job of proactively reaching out to the employees. So it's been a great partnership. for the kind of independent, transparent plans that we do, and they're a transparent PBM. So
Thanks, Mark. Appreciate that. And I will share that through the first 3 months, we're seeing significantly lower average per member per month cost of to date about $34, just under $35. That does not include the impact of that situation that Mark was speaking to. That's not in consideration, and that less than $35 is more than half of what we saw the prior per member per month costs were for Central
Right.
Christian Church. So it's been a good start and a real value. And Matt, if you could go to the next slide, because we do want to take a second to introduce a new employer benefit, Employer's Choice RX, or ECRX, as it's a lot easier to say. We are pleased that our coalition out of Arkansas, the Employers Advanced Cooperative on Healthcare, our employers started ECRX to address the cost of pharmacy and in the issues that it was causing for our employer members back in 2011. And it's produced great results for our members. You can kind of see a graph there looking at our results versus national industry standards over the last 5 years. Our members, as a result, have saved over $4 million compared to what industry spend would have been had they not been a participant in ECRX. And we are very pleased that in partnering with the Kansas Business Group on Health, that ECRX is now a solution that is available for consideration for members of the coalition there in Kansas to consider if you're looking for an alternate pharmacy source. The uniqueness and the difference of a transparent PBM solution of ECRX compared to some of the others, again, this is a solution built by employers for employers. And we think that's a significant difference. When ECRX was started, the employer members' number one focus was a patient-first approach. They wanted to make sure that the patient was able to get the right drug at the lowest possible cost for the member and for the employer. And the second focus is the total alignment with employers and in eliminating what typically is the inherent misalignment of incentives that are seen in the PBM world. So we're very pleased to make this offering available in partnership with the Kansas Business Group on Health. But again, it's most important that as you look at your pharmacy benefit costs, at your approach to managing specialty drugs, as to the importance of rebates in delivering solutions and savings for your plan, network, so on and so forth, you really need to make this consideration based on your priorities as an employer and what is most important to you as you consider your stakeholder for your medical and your pharmacy solution. So if you have any questions, Shelley, Matt, if you all have any questions that you want to present or there have been any presented in the chat box, we'll be glad to take those now. Certainly if you would have any questions or more information about ECRX, we would encourage you to reach out to Shelley or Matt. Again, if you're interested in your per member per month costs, make your way to their website and check out the calculator to help you with that calculation. But I will pause for a second and offer that there are any questions that we'll be glad to take them.
I don't see any questions right now. Anybody have any questions for Bob? Bob, I know, I think I'm getting a little confused, but this is not just offered through the National Alliance. Am I correct?
That's correct. Yes.
Okay.
It's not just offered through the National Alliance. No, that's correct.
Okay.
Yep.
Right. But you do work with other sister coalitions?
We are working with other coalitions like the Kansas Business Group on Health, as well as we are aggressively in 2021, promoting ECRX to other strategic advisors like Mark in other states and in partnership with some other third-party administrators. So ECRX has really been primarily a solution that's only lived for the members in Little Fort Smith, Arkansas. And we are pleased to say that we have a client in Kansas, Wyoming, Illinois, Florida, as we're looking to expand with other coalitions and outside of our home market of Fort Smith, Arkansas.
Okay. All righty. Let's see. All righty, here's a question. Can you talk about how ECRX differs from other transparent PBM models?
That's a really great question. And the biggest, there's really a couple things that that makes us different from the traditional other transparent pharmacy benefit manager solutions. Number one is Employer's Choice RX. We are not a PBM. We're a pharmacy benefit solution. So as ECRX was formed by the employers in 2011, they separated the duties that exist within a traditional PBM. We contract with a national pharmacy benefit administrator, which delivers all of the pharmacies. They handle all of the traditional role and value of what a traditional PBM delivers. We contract with a rebate aggregator to where we do want to capture rebates for employers and pass those along. So we are leveraging their bodies to attract rebates. But the piece that really separates us is the role of our clinical risk partner. And their role is to do two things for the employer and for our plan. Number one, they are managing the specialty drug prior authorization and medical management review. In a typical PBM, that specialty management oversight and approval is handled by the PBM that's also filling the specialty drug. So again, there's a conflict of interest. So we have removed that conflict of interest from the pharmacy benefit manager and have that administered by a separate independent party that's reviewing the prior authorization without influence of a rebate, but with the influence of medical necessity, right treatment for the patient. The second role that our clinical risk manager plays is in making recommendations to the employer on the makeup of the formulary. Again, our focus is not rebates. Our focus is the right drug at the lowest possible cost for the member and for the employer. So where there is a biosimilar or a therapeutic equivalent prescription, our formulary recommendation from our clinical risk manager is to the employer, look, there's a higher cost red peanut M&M that your person can take, but there's also a green, yellow, and orange peanut M&M that's less costly that produces the exact same treatment for the patient. So let's set up your plan to cover the orange, green, and yellow peanut M&M that only costs $30. If the patient wants that red peanut M&M that costs $80, they can get it, but they're going to pay the difference in the cost. Those decisions typically are presented by the PBM, and the employer really doesn't have a lot of option because that's not their plan. In our approach with our clinical risk manager that makes us different, that is our recommendations made to the employer with their broker advisor, but the ultimate decision on how their formulary is put together, considering rebates, considering lowest net cost, considering clinical interventions, is the decision of the employer.
Right. Once again, back to the employer kind of being the driver of the ship, if you will.
They are the payer, and they should have the control to determine how their dollars are spent, and more importantly, the treatment and the best treatment decisions for their patients that are available to them.
Right. And so if I'm understanding then, the ECRX would work with the employer on their formulary. Is that?
Correct. Yes.
Okay.
Yes.
Mhm. All
And
righty.
yep. And with that, there may be different approaches. Again, how much noise do you want to drive throughout your program? Yes, you might be able to save $30 per member per month by tightening your formulary, but we don't want to do that day one. So we can kind of baby step approach in, but and say, look, if you go soft, you're going to save about $15 per member per month. If you go a little tighter, you could save $30 per member per month. Here's the potential noise. Here's a potential disruption. How do you want to approach it? And we consult with their advisor and with the employer and ultimately let them decide how fast do you want to go and how do you want to phase it in to achieve your maximum savings.